Thank you very much, Dr. Wada and Dr. Adira, and also thank you for the Emirates Cardiac Society for bringing this outstanding program to the region. I think this is a phenomenal advance that we specifically address these gender disparities, and there's a lot to talk about. So I'll be talking about update in the pulmonary hypertension guidelines. As you know, the European Society of Cardiology and the European Respiratory Society has updated their guideline last year, and I'm very happy to announce that a multi-society guideline from the UAE has actually been completed and will be presented today. So just to start, I think the idea of pulmonary hypertension is an important one. And the three societies that met and convened about a year ago in this very important project between Emirates Thoracic Society, Emirates Cardiac Society, and the Emirates Rheumatology Society to come up with a comprehensive guideline that takes the UAE perspective into play. So I'm really privileged to be part of this committee. There are many other members. Dr. Muhammad and Dr. Ashraf are from the Emirates Thoracic Society. Dr. Saad Khalid and Dr. Jamal Naqbi are Emirates Respiratory Society. So this has really been a huge task. It's taken us about a year to complete this very important project. So what is pulmonary hypertension? It is the blood flow between the heart and lungs. And I think that's fairly obvious, but there's two components here. One are the pulmonary veins on this side. So this is the left atrium. That's the receiving chamber. And here's the pulmonary artery on this side, which is the forward chamber. And the problem is, if you look at the pressure, we talk about a pressure in the right ventricle of only 20 millimeters of mercury. It's only 20, which is normal. As you go up into the pulmonary artery and you measure that, the left atrial pressure is generally very low. So anything in between indicates resistance in the lungs. Remember, the lungs are full of air and the pressure should be normal or subnormal, right? Anything above 20 is high and leads to RV distress. Now, this is what happens in pulmonary hypertension. The vessel becomes thickened, hypertrophied, almost down to a tiny little hole, and that means the pulmonary vascular resistance is tremendously elevated, and it's not just the smooth muscle. There are endothelial and structural changes that are very dangerous in these patients. Now, pulmonary hypertension in women is very important. Why? Pulmonary hypertension in general is a lethal disease with a mortality untreated 20% per year. This is triple the mortality of heart failure and 4 times that of breast cancer. Think about that. It continues to be missed and not diagnosed, and continues not even to be considered in a differential diagnosis in women with these common phenotypes. Dyspnea is almost always attributed to asthma, wrongly. Fatigue is attributed to anemia, wrongly. Syncope and dizziness, neurocardiogenic syncope, and finally chest pain, non-cardiac or anxiety. What is the problem with that? If you have all of these or 2 or 3 of these in the same young woman, it is a lethal condition, not something simple that you can treat with minor therapies. Alternate diagnoses are always proposed and followed, leading to years of delay in the diagnosis and treatment. And pregnancy often unmasks severe PH with high maternal mortality. And we've actually received many calls from our colleagues. Listen, I have this pregnant patient with severe pulmonary hypertension. What am I going to do? So, sorry, these are my disclosures. So pulmonary hypertension is a general group of diseases. And basically the idea is, when you suspect it, detect with an echo, refer as soon as possible to the Center of Excellence. These diseases are too complex to be managed in general practice. And essentially, the symptoms are often non-specific and can be misassociated with a large number of conditions. So the red flag symptoms to consider are fatigue, dyspnea, and dizziness occurring together in a patient who neither has risk factors for lung disease nor has risk factors for coronary disease. Think about that. Late symptoms occur: chest pain, ascites, lower limb edema, heart failure, and additional symptoms can occur along the way that lead to more distraction: cough, syncope, and arrhythmias. So I think it's also hemoptysis and hoarseness of voice. These are very late symptoms as well. The problem is, if you leave PH, RV failure and death will ensue. And as I mentioned before, the median survival without diagnosis and treatment is 3 years in patients with idiopathic pulmonary hypertension. So we're really doing very badly in this, largely due to the delay in diagnosis and distractors. So what I'm trying to remind you, if you get these symptoms vaguely but persistently in a young woman, think of pulmonary hypertension and get the right test, which ultimately will be the echo. So I'm going to go to the echo. So my problem is, echo is also not enough. We also know this as echocardiographers. Everybody looks at the TR velocity, but if you look at the guideline, you're going to see that this is a problem. The guideline, and this is the older guideline, actually 2015, 2018, and I'll show you the update, tells you that even if the RVSP is less than 2.8 and not measurable, but you have any of these features on the left, pulmonary hypertension is still very, very likely. And what is it? A dilated right ventricle. So what we call the D-shaped septum, or the flattening of the interventricular septum. That's got to be explained by volume or pressure overload. Next, a dilated pulmonary artery. If you see a dilated pulmonary artery, even if the TR velocity is less than 2.8, this patient has pulmonary hypertension until proven otherwise. Next, if you have a dilated IVC or right atrium, and the magic number is the right atrial area more than 18. If you don't do this, you should always have your techs measure the right atrial area, because it's going to discriminate between a dilated right atrium or not. Any dilated, and also even if the pressure is not high. Now, if the pressure is high, it's obvious, but if it's not, that's the orange zone, you still have a very strong likelihood of pulmonary hypertension, and you need to work on this process. Now, the updated 2022 guidelines from ESC are even more complicated. There are now 16 essential elements to look at the right ventricle. So it's not enough just to report the pressure. It's not enough just to say the right atrium is big. You have to do a lot of other things. And one of the new things that have been validated is this. This is the RV acceleration time, or the presence of a notch. Sometimes you don't get enough TR velocity, but you can always get a pulmonary artery, and you can almost always see this notch on the Doppler. Again, findings of a dilated RV in any of the 4 views, findings of a reduced TAPSE, findings of a reduced S prime on the RV, right? And also a dilated right atrium. So these are key things to measure, and we have a poster like this, which we will give to the echo techs so they don't miss any of these findings. And if you see an echo with only the left ventricle, you've ignored 50% of the heart that can be contributing to the symptoms. Unfortunately, we see a lot of those echoes, and that's not standard. So this is how these patients are missed, and that's why they're told, you're just anxious. That's not right. So this is one of the important parts of the guideline. It's a very large document, but I wanted to focus on the idea of center of excellence and fast track referral, the rationale and why. And I think this is one of the main things we've noticed in the UAE, very late referrals and lack of presence of resources. So the definition is very simple. Breathlessness in pulmonary internal medicine, cardiology clinic, and of course now the obstetric clinic should lead to a standard investigation, a detailed echo. The next step, if it's abnormal, fast track to center of excellence. And fast track means 1 to 2 weeks, not months, not days. Center of excellence is designed to take these patients quickly and process their symptoms and get them on treatment. We actually just copied this from the European Society of Cardiology guideline, just to make it very consistent. Some simple things that you can do in the outpatient setting. The history, recurrent syncope and persistent shortness of breath. Remember, asthma is an intermittent disorder. It should not cause persistent shortness of breath. An abnormal ECG, murmurs, an elevated BNP, and something that nobody does in the outpatient setting is oxygen saturation. You really have to do this simple test in patients who complain of breathlessness. If they're low saturation or you make them walk and they drop, that's even worse. All of this is within the guidelines, but the most important part on the left, fast track to center of excellence. And this is important because our patients present extremely late, which I'm going to show you in a few minutes. Now, what happens at the center of excellence, which is the urgent referral, is a lot of things that go on this table. There's about 11 different tests, a lot of algorithms that have to be followed. So what is the center of excellence? What is it? So this is what the center of excellence does. It has to have specialized outpatient services. We have to access emergency care. There's a whole lot of imaging here, including VQ scan, MRI, lung function test, and most importantly, cardiac cath. We also must have the full range of PAH and CTEPH drug therapies and the pharmacy to support it. We have to have the expertise in the ward staff. Now, as we get worse, and this is the pathway, ECMO, intensive care, lung transplant, and finally, PEA. So to be a center of excellence, you gotta have all of this and also some more things. The other important point that we've noticed, and this is something we discussed in detail in the guideline, is because we get obstruction from insurance. And this is one of the things we convened multiple meetings with the insurance companies, most important which was Daman, to tell them that Center of Excellence has a specific role. And we were able to convince them finally under what we call the adult cardiothoracic mandate, which Daman has accepted since 2015, is that the right heart cath and nitric oxide challenge has to be done at the Center of Excellence by our definition and international guidelines. And therefore, we've been able to accept a lot of the non-UAE nationals, and a lot of the expats because of the ability and feasibility of this. The guidelines also tell you what are the core therapies, core specialties you have to have. At least 2 PH specialists, more than 1 PH nurse. You have to have an interventional radiologist or cardiologist for what's called the diagnostic pulmonary angiography. In addition, a study nurse, we also have to have 2 ECMO-capable surgeons, cardiothoracic anesthetist, and we notice here the gynecologist and obstetrician, which is for the patients who are pregnant or becoming pregnant, hepatologist, intensive care, physiotherapist. A lot of elements are needed to maintain this excellence. Now, just to summarize the important things which we tell the patients and we tell our colleagues. To diagnose pulmonary hypertension, a right heart cath is mandatory. An echo can tell you the likelihood a right heart cath must be done in a specific way. You never treat empirically. So many of our patients, almost 80%, receive low-dose Viagra on an empiric basis. This is extremely dangerous and not supported by the guidelines. The right heart cath has to be done at the Center of Excellence, and I'm going to show you why. It's in the guidelines, specifically because there are specific standardized protocols at the center. All of these elements are needed for a proper right heart cath. We have unfortunately seen right heart caths which say, pulmonary artery pressure is this, wedge pressure is that, thank you. Where's the cardiac output? Where's the saturation? Is there a shunt or not? What's the pulmonary vascular resistance? What is the stroke volume index? What is the RV function? So all of this has to be done in a lot of detail, and in fact, we have to train our technicians to collect all this data and make the calculations before the patient leaves the room. And the next is vasoreactivity testing. You do all of this, then you repeat it again with nitric oxide or IV epoprostenol. Very detailed assessment cannot be done lightly. It changes the patient's prognosis and therapy. The next is structured follow-up. Structured follow-up means we do a lot of things every single time the patient comes. Minimum 6-minute walk and BNP. Now, one important point, and the guidelines have broken it up into red, yellow, and green, green being the safe zone, red being the high-risk zone. It's not acceptable to even be intermediate. You can't be yellow. You have to be in the green zone. Why? Because if you're intermediate risk, mortality is still 10 to 20% per year. So we have to keep pushing the envelope and finding these patients. So low threshold to repeat the right heart cath and echo if not improving, i.e. intermediate, and obviously if worsening, and we have to escalate therapy fast. So these are the therapies that target the signaling pathways. And I'm going to tell you, as of 2016, every single guideline is telling us you cannot use monotherapy. You have to use combination endothelin and nitric oxide. Why? The AMBITION study showed using monotherapy increases mortality by 50%. It would be like heart failure without an ACE inhibitor and a beta blocker. Simple analogy, it doesn't happen. Everybody comes in low-dose sildenafil. It's ridiculous, it's dangerous. Now, this is what we do in structured follow-up. Without going into the details, symptoms including syncope and functional class. Syncope is featured in the WHO classification of PH. It's not in the heart failure classification. Why? If you have recurrent syncope, the risk goes up to 20% in 1 year. That's the problem. It's a very serious progression. You do the cardiopulmonary stress test. You do the NT-proBNP. These cutoff points are lower than the heart failure cutoff points. But if your BNP remains over 1,100, you're a high-risk patient. Your right atrial area, again, comes back. So we have to do echoes frequently. And we're looking at pericardial effusion. Pericardial effusion here is significant, not in that you want to tap it or not. The presence of pericardial effusion indicates high pressure. It's a high-risk marker. And of course, looking at cardiac MRI parameters. And finally, repeating the right heart cath. And observe what is considered normal in a right heart cath. In a PH patient, all 4 parameters, low right atrial pressure, improved cardiac index, stroke volume index, and SVO2. The cath has to include this information. It's so important. So pregnancy in pulmonary hypertension is another really serious problem because unfortunately we get calls all the time. I have a pregnant patient, severe pulmonary hypertension, what am I going to do? Okay, it's a disaster. It should not have been allowed to happen, and we have very limited options. So one of the things is this. If you have a symptomatic patient who's pregnant, an echo is recommended. There's a 1C evidence guideline. This patient, look at this ECG. What does this look like? This is RV strain with RVH, labeled as asthma for 6 years. Ridiculous, unbelievably dangerous. And this patient came to us pregnant, not due to bronchial asthma. So what about doing the right heart cath? Can you do a right heart cath in pregnancy? Absolutely. to confirm the diagnosis, but with very strict indications and with a lot of shielding and a lot of protection. As all of you know, we can generally do the right heart caths in the bedside without fluoroscopy, and if we need to, we can use very limited fluoroscopy just to see the tip of the catheter. So, very important, and this is key point. Next, what is the mortality in pregnancy? So I mentioned to you it's above 20% without treatment. In the non-pregnant person, it's almost 30% mortality. And looking at other conditions, and Dr. Ghadira is the expert here, Eisenmenger syndrome, cyanotic heart disease, low ejection fraction, this is the highest of all these groups. So what about therapy in pregnancy? So very important, you have to look at what is available in pregnancy, and it's unfortunately very limited. You cannot use endothelin antagonists. They affect the fetal lung circulation. You cannot use nitric oxide pathway. There are small studies and they show there's some issues with fetal growth. The only therapy we can use is intravenous prostacyclin pathway, IV epoprostenol. So this is a very serious condition, and we start these patients on these therapies immediately. So that's really where we're sort of stuck, and this is one of the cumbersome therapies that requires a permacath and a pump. So I'm going to come back to the Pulmonary Hypertension Center because I think this is something that we have established as a resource for the entire UAE. The U.S. Pulmonary Hypertension Association has resulted in accreditation criteria. We've incorporated these criteria built into our program. And there's two types of program, a comprehensive center or a referral center. So one of the important points is this. Number one, accept any PH patient from any other center in fast track. And we actually have to have the support of our hospital administration. This has been a very successful program, and we're going to describe the statistics for that shortly. The other resources are this: VQ scan, right heart cath, vasodilator testing, and parenteral prostacyclins. But ventilation perfusion scan is a must in the non-pregnant patient. Why? Because we're going to see a couple of patients that have a normal CT pulmonary angiogram, i.e. no pulmonary embolism, but there's distal disease, which is called CTEPH. You can't see that on the CT scan. The other thing is you have to have pulmonary transplant, you have to have cardiac anesthesia. You also have to have the ability to manage IV and sub-Q infusions, i.e. the nursing and the pharmacy and the physician support of this. So since 2015, we have had, unfortunately, approximately 41 patients who are on sub-Q and IV treprostinil. Now, there's an innovation that was developed in Germany, and this is this internal pump. This pump has a reservoir with 40 cc's. That's actually just enough for a month worth of therapy of these sick patients. And we're sending the patients to the specific center, and they implant this device in the abdomen. It's tunneled up through the superior vena cava into the heart, and then we just fill it every month through a subcutaneous injection. So the patient has nothing outside, no tubing, no needles, nothing. We have 7 patients on this. This is literally the largest series outside of Europe that has this group. The other point is research and registry, and I think this is a key point. We must be part of registries, and I think we are very proud of this particular achievement. We are the first center outside US, Canada, and Europe to be enrolling in a phase 4 randomized control study in pulmonary hypertension. And I have to thank the team, Dr. Muhammad Khalil, Dr. Ahmed Sharif, Ahmed Bafadil. The entire team went through a very rigorous interview process to see if we could qualify for this international RCT. So we also have to have a dedicated research pharmacist as well for the investigational drug. So I'm just going to run through our team. This is something we're very proud of. We actually have a very large team. Dr. Manu is our new cardiologist. He's also a cardio-oncologist, but has a lot of experience in pulmonary hypertension, was part of clinical studies. My colleague, Dr. Khalid from pulmonary, Govinda is also from pulmonary, and we're very proud to have Dr. Osman, who's our head of transplant and thoracic surgery. We have 3 nurses and 1 dedicated nurse in the cath lab. We have 2 pharmacotherapists and 1 very important pharmacotherapist who deals with the outpatient clinic and deals with the insurance to get approvals. So this is actually our team. Some people may be missing, I apologize for that. So in terms of the registry, we've had 417 patients referred to the program. And since January of 2021, we've had 158 emergency transfers to hospitals all over the UAE. That's the fast track approach. And this is our organ transplantation outcome. So the lung transplant program was restarted in August of 2022. 4 of those patients are severe pulmonary hypertension patients. Usually these patients stay on the waiting list long. We were very fortunate to get them in very quickly. These are patients on IV, sub-Q, triple therapy, failing with a lot of complexities, a lot of comorbidities, and fortunately all of them have been discharged, and you may have seen some of them on some of the TV programs in Abu Dhabi TV. Also, we cooperate with our liver transplant team, so there's an entity called Porto Pulmonary Hypertension. You transplant the liver, portal hypertension disappears, pulmonary hypertension disappears, RV remodels. Two very successful cases who are advanced on triple therapy. So this is a testament to this multidisciplinary nature of the team. This is the growth of our clinic. Thanks to all of your referrals, we've basically now exceeded 420 in this year alone. So what about the outcomes? We have to be transparent about the outcomes, and we have to explain the gaps. So 50% of our patients were classified in that red zone. The 1-year mortality is more than 20%. Initial presentation. Our 1-year survival is 88%. Our 5-year mortality is 14%. And a 95% survival rate in those patients following in the clinic regularly. 76% newly diagnosed transfer patients, the survival is less. Why? Because they present very late. Sometimes we cannot salvage them. And of course, the surgical patients we'll discuss shortly. We had 31 patients with chronic thromboembolic pulmonary hypertension cured with surgical balloon or surgical balloon endarterectomy. Up to November 2022, we were sending abroad. Now we've actually done 3 cases. So this is our actual 1-year survival. 88%, 5-year survival, 76% in a very high-risk group of patients. So I think this is something we need to improve, but it's at least consistent with the guidelines. We sort of published this in the American Thoracic Society meeting, same exact data, but this is important, and we've shown this. The patient's early referral on the top dotted line, patients who come to us in the clinic survive much, much better than patients who come to us really sick, which is the green line as well. We've also had the ability to publish on our IV and sub-Q patients, and this is sort of a miserable slide to show. Out of 25 patients with advanced functional class who were on IV or sub-Q, we actually have only 60% surviving. 40% have died, and we've looked into the reasons, and one of them is very sad. Insurance interruption for unclear reasons, and other physicians unaware of the therapies telling the patients to stop. So this is one of these dangerous things that we've come up with a recommendation, that we really have to be careful. These patients have to be red flagged. Nobody should touch their medications. And we've been fighting with the insurance not to interrupt these medications if there's a Eid holiday or any of these ridiculous excuses. They have to get the patient the medication. Now, what about CTEPH? What is chronic thromboembolic pulmonary hypertension? It's a special form of pulmonary hypertension. It's caused by non-resolving pulmonary embolization. And you notice here, there is no filling defect in the lumen. There's nothing in the lumen. But the wall becomes thick and remodeled, just like atherosclerosis. And the vessels become, the branches become occluded. And all of the branches gradually become slowly occluded. So if you have proximal disease, as you see in A, then a surgeon can remove this white substance, which is basically a fibrosed shell on the inside of the vessel. If it's more distal, balloon pulmonary angioplasty works very well. And the unfortunate patients who have distal disease can only tolerate medical therapy. So we actually presented our data last year at the ATS meeting. We had 26 patients sent abroad, both UAE and expats, due to the generosity of many charities in the UAE. I have to say this is something very heartwarming. And 100% surgical cure. Not one of these patients has now pulmonary hypertension. They only need to be anticoagulated. Now the amazing thing is, our brilliant surgeon who also does our transplants also decided to commence this program. This is one of our first patients out of 3. 34-year-old gentleman from Al Ain transferred on, very sick, on actually IV inotropes. We put him on triple therapy, and you're going to just notice in the yellow bar is his mean pulmonary artery pressure, 94/34, and above it is the systemic arterial pressure, 110/55. This is unbelievably high. This is on triple therapy with oral medications. Cardiac index is low, and the pulmonary vascular resistance is high on triple therapy. The CT scan from the outside hospital typically said there is no pulmonary embolism. Of course there is no pulmonary embolism. It's not. There's not a filling defect. It's now become an obstructed vessel. So we do a selective pulmonary angiogram, and I don't know if you can see this, but you can actually see the stump occlusion. There's literally no vessels here or here, and here's another stump occlusion. So there's basically nothing going forward, and that's really the key point with this. So Dr. Osman operated on this man November 11th, 2022. Look at this. This is the substance that's removed. These giant chunks obstructing the coronary arteries, pulmonary arteries. So this is the starting pressure. This is the same day coming out of the operating room, no therapy. 45/25, drops by 50%. Normalization of pulmonary artery pressure is expected. We repeated the right heart cath the day prior to discharge. Pulmonary artery pressure 26/13, mean of 17, curing a severe condition. So I think this is why we've pushed forward this program to prevent these patients from progressing to transplant or requiring long-term therapy. Now, we're also doing a lot of programs supported by Emirates Cardiac Society, Emirates Thoracic Society, PAH Academy. Our last meeting with Emirates Thoracic Society, we had 1,800 attendees because it's a virtual platform. So there's another very important point. These medications that we talk about are very expensive. So after working with the Department of Health and the Ministry of Health, this is a patient support program that is industry sponsored but goes through a charity. And they have now 38 patients fully supported with these two medications that would basically cost about 1 million dirhams if the patients was on their own. So this is a very important point for us to maintain the therapies in these poor patients. Donor education on lung transplant is very important. We're part of this discussion to encourage people about the core culture of organ donation, particularly with motor vehicle accidents. And that's another outreach program that we do. There's an additional patient support program that goes to the patients with pulmonary hypertension at their houses and looks at their side effects and also talks to the physicians and liaises with them frequently. Now, in the last few minutes, I'm going to talk about this terrible case. Oh, yeah, sure. This is a really terrible case, which I actually had to manage before I came to the UAE. And it's sad, and I really want to highlight why we need to do this. So this is a 32-year-old female, 24-week pregnancy, exertional dyspnea, fatigue, and palpitations, history of breast gastritis, and a left breast fibroadenoma. Not very significant. So she's BMI of 23, blood pressure stable, heart rate tachycardic, not hypoxic, but functional class 3. Every time she walks, she feels very dizzy and lightheaded and has near syncope and shortness of breath. Was discounted again as bronchial asthma, fatigue, and all the other foolers. When we did a 6-minute walk, 164 meters. Now, the normal 6-minute walk for you and me, I'm very obese and I'm not well conditioned. 440 meters is the minimum for a healthy person. This indicates severe cardiovascular distress, and she's very symptomatic during walking. This is this woman's ECG, not bronchial asthma. Obviously, RV strain with RVH. So, labs, mildly anemic, and this was another fooler. But of course, this patient was being seen in our center, and in addition to all of that, we did an NT-proBNP, 3,500. So one of the important points that's come up in the recent ACC guidelines is for patients with dyspnea, an NT-proBNP should be like an automatic test because it's going to give you cardiac or non-cardiac, and then direct you also to do the right thing. So as I mentioned, echocardiography is important in any woman with pregnancy and pulmonary hypertension. I couldn't upload the videos, but I think you can see very clearly that the RV here is very large. The right atrium is pancaking. The left atrium is tiny. It's collapsed. And of course, there's a small pericardial effusion. This is what we call the classic D-shaped septum on the right side. So you can't miss this. You can't miss this. The TR velocity exceeds 40, exceeds almost 90 millimeters of mercury. And as I said, that's not even essential. Just looking at this picture here tells you the patient has pulmonary hypertension. And this is what we talked about, the echocardiographic suspicion. So don't get fooled. If you don't see an elevated TR velocity, but the chambers look big, this patient has PAH until proven otherwise. So these are the different types of pulmonary hypertension. I won't bore you with the details, but they're important because we do the tests to find them. Some of these things are reversible. Some of these things are connective tissue disease. You don't know, but you have to find the actual diagnosis to treat properly. At the expert center, we start with a VQ scan and we go to the right heart cath. The VQ scan cannot be done in this patient, so we went directly to right heart cath. Now, if you look at the chest x-ray, I think it's entirely clear that you have a giant pulmonary artery. You can't have missed this. I don't really know historically why this was missed. It's very sad. As I mentioned, right heart cath can be done in these patients, even we do it in the bedside in the coronary care unit or CCU. So the definitions have been recently updated. Now the mean pulmonary artery pressure used to be 25, it's more than 20. At the same time, the type of pulmonary hypertension that we treat, which is precapillary pulmonary arterial hypertension, you also have to have a normal wedge pressure. If your left atrial pressure is high, this is a heart failure patient, and you don't treat them with vasodilator therapies. That can be very dangerous. Also, the pulmonary vascular resistance has to be more than 3 Wood's units. So at a minimum, if you do a right heart cath, you got to come out with these numbers. So this lady's PA pressure, 123 over 47. And the PA pressure is wedge is less than 10. So her FIC cardiac index is 2.9, fortunately preserved. The PVR is 1,000. 1,000. Normally, you're talking about 150. So this is really serious. Now, in many of the hospitals that we work at, particularly this was at Rhode Island Hospital, we have a pregnancy heart team specifically made for these patients, including a cardiologist, a thoracic surgeon for ECMO, also the intensivist, pediatrician, obstetrician as well. So it's a lot of work being done for these patients. Sorry. Can I? No, it's not. Can you unloop? Sorry. Yeah. So that's a strong move. Yeah. So. Yeah. Okay. So as we progress with this case, obviously we realize this is an extremely serious condition and the patient obviously is already mid-pregnancy. What are we going to do with this patient? As I mentioned, the only treatment you can give is intravenous prostacyclins. Can you...
Can you please continue the slides because yeah. You have time, Dr. Hani. You can...
All right, thank you. So the idea of intravenous prostacyclin is not a small one. It's a big challenging problem. Okay. Yeah? Can we move forward? Screen. Okay, good, thank you. And you're all very familiar with this classification of cardiovascular diseases in pregnancy. And I'd just like to highlight to you in the group 4 up there, along with ejection fraction less than 30 are patients with pulmonary arterial hypertension. So, and it's listed with severe valvular heart disease and many others. So it's a very severe condition to have. We mentioned the mortality in this group of patients. So if you look, and this is what we do in the clinic, this is called a risk stratification scheme. It's not something you normally do in other forms of cardiology. Every one of these items has to be challenged. So her hemodynamics was okay with a CAA of 2.5, but she has a low functional class, a very low 6-minute walk. She's rapidly deteriorated. Her BNP is over 1400, big right atrial area and a pericardial effusion. She's automatically high risk, which means the mortality exceeds 20% in the next year. And that's without being pregnant, okay? The treatment in high-risk patients has to be IV and combination therapy. So normally if she wasn't pregnant, we'd give her triple combination, IV and 2 oral therapies. We're stuck now. We cannot use these 2 pathways. So we have to go to the IV and give very high doses and escalate. This medication has tremendous side effects and is really hated by physicians and patients at one, but there's no other solution here. So this is what we do. We insert a tunneled catheter and then we start with epoprostenol at 500 and then we go up basically in 1-day dosing to rapidly rescue the patient, but the side effects are tremendous. Bone pain, headache, nausea, vomiting, dizziness, diarrhea. This is one of the worst medications you can give a patient, but we have no options. Also diuretics and spironolactone. We gave the patient low molecular weight heparin and iron supplementation. You saw her TSAT was very low. And a planned C-section was decided by the multidisciplinary team. And we may debate that, but I think that was the ongoing plan. So 4 weeks on treatment, we got the PA pressure to 106/39, wedge pressure of 10. Cardiac index has now improved significantly. Now remember, I showed you the original cardiac index of 2.5. That would be okay if you're not pregnant. During pregnancy, the cardiac output should be at least 4 times higher. So we were already way behind in the pregnancy with the cardiac index and a lower PVR. So the ECMO team was actually brought into the C-section room. This was done at Rhode Island Hospital. And we had everything ready to go. We did not have to go on ECMO, and she was able to survive. And this is sort of a picture from that patient. So after that was done, we then switched the patient from IV because there's a risk of infection to sub-Q prostacyclin. We switched her to warfarin and put her on diuretics. This is sub-Q pump here. It's like an insulin pump that's modified. It delivers the medication 24 hours. 5 months later, she's functional class 2. Oxygenation is better. BNP from 3,000 to 159. 6-minute walk is 512. What did the patient tell me? I knew the pregnancy made me ill. I was fine before. I'm going to stop the medications. Cold turkey. She just stopped. So that's when we last saw her. The RV function had normalized, only right axis deviation, no RV strain. That's when she decided to stop her medications. And if you looked, we had multiple echoes, and you see the RV was basically getting smaller and the right atrium was improving, no pericardial effusion. She unfortunately got divorced, lost the follow-up, and then I got this very sad email when I had already moved to SKMC. Her ex-husband emailed me and said she passed away in another hospital. Excuse me for being a little emotional. This is serious. Anyway, so I think it's conclusive that PH often manifests first during pregnancy. Very high risk of maternal mortality or severe morbidity, which is the WHO classification 4. In women with PAH, pre-pregnancy counseling and management during pregnancy is really should be done at an expert center with a multidisciplinary pregnancy heart team. And the plan really ideally should be between 20 to 30 weeks of pregnancy, induction, management of labor, delivery, ECMO, cardiac surgery, and most critical times are peripartum, often within the 3 months of delivery. And thank you very much.